So what we're going to go over now is the assessment for a unconscious, unresponsive trauma patient. There's a lot of different routes you can go on the assessments. You know, there's a lot of different patients you're going to experience unresponsive, responsive, trauma, medical. But what we're going to go over is the trauma unresponsive section. So, of course, the first thing you're going to go over is your scene size up. When you come up to a scene, you're going to check and make sure that the scene is safe. Your personal safety is always your number one priority. So you're going to make sure that you have the proper PPE, which is going to be gloves, or, well, definitely always gloves, but sometimes you'll need a little bit more PPE, such as a mask, a gown, booties, things like that. The next thing you're going to determine is the number of patients that you have. So a lot of times you're only going to have one patient, but sometimes in wrecks and larger incidences, you will have more than one patient, and you're not going to be able to handle it with just you and your partner. So you're always going to be keeping in mind, do I need to go ahead and request additional units, additional resources, or can we handle it ourselves? The next thing you want to look at is the MOI or NOI, mechanism of injury or nature of illness. In this, it's going to be a trauma patient fell from a ladder approximately 10 feet. So that's definitely going to be a mechanism of injury due to the trauma. So you're going to consider C-spine. And now your C-spine stabilization is meant to keep from furthering any kind of cervical spine injury. And generally one person is just going to hold that C-spine for the duration of the call. And you know, once you get the patient backboarded or whatever the case may be, and get him strapped down, you'll be able to release that. But for the purposes of this demonstration, I'm not going to hold C-spine the whole time because I'm going to be doing other things. So just kind of imagine that somebody's here holding that C-spine. The next thing you're going to do is when you approach the patient, you're going to check the responsiveness of the patient. And remember our mnemonic AVPU, which is the first level alert is going to be just addressing them with your voice. Hey buddy, are you all right? Hey, no response. So we're going to move on to the next one. You know, that was your verbal. Then you're going to go to touching him. Hey, are you okay? Hey. I mean, you don't want to shake him. You don't want to rattle him. You don't want to cause any more injury to that C-spine if there is one, or any additional trauma. And then you're going to give a painful stimulus, which can be a couple of different things, but the most common one is a good sternum rub. And in order to do that, you're going to take your knuckles and you're going to place it right on the blade of their sternum here in the plane, and you're going to give them a nice rub. Okay? Give them kind of a hard rub. You're not going to hurt them just by rubbing them. I mean, you are going to cause them a little bit of pain, but you know, sometimes they'll draw into that pain, and that's going to be your painful level of alertness. And then the next level is unresponsive. So if they don't react to that good sternum rub, then you know that they're unresponsive, and you're going to be in trouble here. So at this point, you're going to start your primary assessment. And you've already sort of started your primary assessment as you're walking up to the patient when you're gathering your general impression. You're going to be listening to see if you can hear any odd airway sounds, any odd breathing sounds. You're going to see a little bit from a distance the rate at which they're breathing and the quality that they're breathing. If they're breathing shallow and fast, or slow and shallow, or slow and deep. You know, these are all things to keep in mind as you're going through your assessment. So the first thing we're going to evaluate is the airway. And if they're not moving air very well, and you may hear or you may not hear some sort of airway obstruction, some sounds coming from their upper airway, you're going to perform the modified jaw thrust, which is for trauma patients. The head tilt chin lift technique is for medical patients, but you don't want to do that because it might aggravate an injury. So the modified jaw thrust, you're going to place your hands on either side of the patient. You're going to find the back of the jaw here, and you're going to kind of lift up on the jaw, trying not to lift, relax for me, trying not to lift the head, but simply just to lift the jaw up and opening up this airway a little bit, okay? Once you've gotten your airway taken care of, you know, there may be some sort of obstruction in the airway. You may have to go in with McGill forceps and remove it, or whatever the case may be. But normally in trauma, you're going to find that their tongue is going to be the most common airway obstruction, because they're completely unresponsive. All of their muscles have gone limp, and that tongue is going to fold back and occlude the airway. So the next thing you're going to do is you're going to get an oral airway, if that's the case, if you feel that the tongue is in the way. And you're going to check for a gag reflex. If they have no gag reflex, you're going to insert that oral airway upside down, insert it into the mouth, and turn it. Okay, if they have a gag reflex, of course you can't use that. So once you've gotten your airway situation taken care of, they're getting air adequately in and out, you're going to move on to breath, okay, if they're breathing correctly. So like I said before, they may be breathing too fast, too slow, too deep, too shallow, whatever the case may be. And you're going to want to give a quick listen and see what you can determine. I've got my stethoscope here, and we're going to check a few breath sounds just quickly. I mean, the primary survey, as I said before, is just to identify any life threats. So you're going to check and make sure that the air is traveling into the lungs. You're going to check and see if it's traveling into both lungs. And if you hear any sort of diminished breath sounds on either side, and you know, this is going to be indicative of, you know, possibly an pneumothorax or a hemothorax, where you're getting pressure internally on that lung and it's not allowing it to fill, or the lung has been punctured, which again will not allow it to fill with air. So we're just going to check real quick. We're going to listen to breath sounds on both sides. Okay. The upper, the lowers, and on the sides, kind of toward the back, is the best way to hear what's going on in the lower part of the lungs, okay? So once you've determined that, if there's no problems there that need to be fixed, which of course in a primary assessment you're going to fix everything as it comes. You're gonna have to deal with those life threats as you find them. So if there's nothing going on with the breathing that's fixable and that is not life-threatening at this point, you're going to move on to the circulation. And it's a good practice that while you've got your stethoscope, listening to sounds, just real quick, place it over the heart, listen to see if you hear muffled heart tones or some sort of irregularity. They could be in some arrhythmias. And of course, you're not going to be able to identify most of the arrhythmias without being on a monitor, but you know, it's good to know before you even get started whether or not you have an irregular heartbeat. So another point to check on the circulation, if they're not breathing and they're unresponsive, you're going to check a pulse, you're going to check a carotid pulse. If they are breathing, then you're going to check radial pulse, which is found right here on the wrist, kind of in this little notch. You'll feel it. And it's a good practice, you know, if you find the radial pulse, that means their blood pressure systolic is at least at a 90. And it's always good practice to check both and feel both at the same time. And what that's going to do is that's going to tell you if there's any kind of injury that's preventing circulation from one side to the other. So if we've got equal pulses, equal radial pulses, that means we've got a 90 systolic blood pressure that's traveling to both of the upper extremities. Okay? And the next part is you're going to check for any major bleeding. So you're going to kind of look around the patient, see if you see any blood pooling, anything, any bleeding coming from anywhere that it shouldn't be. Look him up and down. Also, it wouldn't be a good idea to just check that abdomen and see if it's, look at it and see if it's distended out. If, you know, you can tell by people's body types what their stomach should sort of look like. And if it's really, blown out, distended, stiff, that means that there's a good possibility that they have some sort of internal bleeding. So there's no major bleeding to stop. You won't have to apply a tourniquet. You won't have to apply any gauze or anything, any pressure, unless you find something. The next thing you're going to do is a secondary assessment, which is your head-to-toe exam. And you're going to start by looking here at the head. Of course, you got somebody that's maintaining your C-spine at all times, but you're going to check the ears, see if there's any clear liquid coming out of it, any blood coming out of it. You're going to check around the mouth, in the nose. You're going to go ahead and take a peek at the eyes, check for reactiveness in those pupils. You're going to take your light and run it across the pupils and see if they react. You're also going to check and see if both of the pupils are equal in size. Now, if your pupils are not equal in size, you've got one that's blown out real big and one that's small, or one that's normal and one's big. That could be a good indication of a head injury. So that is definitely something to keep in mind, especially when you're considering your transport determination. So when you're finished with your primary survey, that's when you're going to do your transport determination, whether you need to just go ahead, throw this patient on a backboard, well, not throw them, of course, but put the patient on a backboard and put the patient in your ambulance and head down the road, or if the region that you're in allows for it or has the resource, they may need to be flown out. And being flown out has its benefits. You're looking at the same services that you might receive in an ambulance, except they can bring blood with them. They can go about 120 or more miles per hour in a straight line to the hospital. So that's going to cut down on your transport time significantly, especially when you're in some of these rural areas of the county where you've got really windy back roads, and you don't want to be trying to do a bunch of interventions while you're doing 70 miles an hour down a curvy road, unless you just really have to. So always keep in mind that you may be able to fly, you may not. They may meet the protocol for it, or they may not. So back to the secondary assessment, you're checking all that. You're going to check the sides of the neck. You're going to check for jugular vein distension. You're going to check for any kind of deformities. Remember your DCAP BTLS during your second survey. So you're looking pretty much for any kind of abnormalities. Another big thing that is battle signs, the bruising. And that's kind of a later sign. So if you're finding this bruising that is not old, that's from this incident, you're probably already behind the 8 ball. So we're going to move on down, we're going to palpate, and we're going to expose. So what we're going to do is we're going to take our trauma shears and we're going to cut. And we're going to cut the clothes off of somebody. Okay, you're going to want to completely expose every inch of them so that you can see any sort of extra injuries, any DCAP, BTLS that you might find. Check the arms real quick. You're going to palpate every inch. Feel for deformities, anything like that. The chest, you're going to check the chest and see if it's stable, good. You're going to go down the flanks, palpate the abdomen, feel for any rigidity or any sort of tenderness if they're able to tell you if it hurts or not. You're going to move down to the hips and you're going to check for stabilization. You're going to press in and down and check and see if those hips feel stable to you. And then you're going to move down the legs. You're going to feel, of course, we've already exposed all of it. We're going to cut the pants off, the shirt off, everything off, take the boots off so we can get a good view on it. So we're going to palpate. We're going to palpate. No deformities or anything. Go down this leg. And then, of course, you're going to expose the feet, check the feet, see if there's anything, any deformities down there, any broken bones or anything of that sort. And, while you're doing that, you usually have a fair amount of help, especially around here from first responders. So, you can get a lot of things done at the same time. Well, one person is doing your secondary survey, another person can be gathering vital signs, or, if there's family